Regarding, you were talking about the computer and the video game, about even the monitor of TV. Is there any particular thing that you don't want them to see for a long period of time, I'm sure, TV? So is there any particular, from your point of view as an advice of an ophthalmologist, that children should see only this much TV or this many hours or strain anything like that?
Strictly speaking, there is no contraindication to actually you cannot put in a time frame wherein beyond, you know, within this it is, within this it is safe and beyond that it is not safe. It is again like, you know, depending on the eye, the amount of strain. Obviously speaking, you don't want your kid to be glued to the TV for hours together for all other reasons also.
Yep, exactly.
So everything said and done, 3 to 4 hours of TV is not going to be a major detrimental factor for the eye. It depends on the eye again and the distance whatever you maintain, the posture you of course you have when you're watching TV. Most of the children, you see them, you know, lying down, and in a lying down posture they watch TV. All that is going to cause a lot of eye strain or asthenopia. So it is always better that you maintain the proper posture and maintain a stipulated distance so that, you know, the eye is free of strain.
Okay, now moving from children to seniors, now what is a common thing? I'm sure cataract, everybody would have said with the cataract, everybody's heard that word. Now what do you advise on that? Cataract, what is it first?
See, the overall blindness pictures around 45 million, which is expected to double to around say 80 to 90 million by the year 2020. A major chunk of it is constituted by cataract. By cataract, what I mean is clouding of the natural lens. One should understand that cataract is not a disease. It is not a pathological change. Cataract is a physiological change. Like at 40 years, you have the natural lens that becomes hard and a little bit, you know, hardening of the lens, wherein it's not able to relax and contract as it's supposed to be. That is presbyopia. The same natural lens, once the patient invariably crosses the age of say 60, what happens is it starts getting clouded. So the cloudiness of the lens is what is cataract. It is not a disease. It's to do with aging. Most of the cataracts what we see is because of senility or aging, and it is not a pathological thing. And one good thing about cataract is of the 45 million or beyond, now the blindness statistics is going beyond 50 or 60 million. So that being the case, cataract forms the major chunk of preventable blindness.
Okay.
If at all I'm going to pick up a patient of functional disability or optical disability who's having cataract, and if you're going to treat them at the proper stage, you can give back all the original vision whatever was there before. So the good thing about cataract is it forms the major chunk of preventable blindness.
Good to know. Okay. Yeah. So what do you do in a cataract surgery? See,
again, cataract, the only treatment, once the particular lens has become white, so there is no medical treatment or the Ayurvedic treatment or any, you know, other alternative forms of medicine that can treat cataract. The only option that is available for a patient is surgery.
Okay.
Okay, by surgery, again, cataract surgery has evolved so much. And you ask any ophthalmologist, they'll be more than, you know, proud to say, like more than happy to say cataract forms the bread and butter for, you know, an ophthalmologist. And the surgery also has evolved so much from the days of couching to intracapsular cataract extraction to sutured, you know, cataract surgery, which we call as extracapsular cataract extraction. Now the technology is so much advanced that we have shifted on predominantly to sutural surgery called as phacoemulsification.
Okay.
Okay, by phacoemulsification, say first let me just take you all across through the extracapsular time, how cumbersome cataract procedure was and how nice it has evolved, so that, you know, people should not, like, you know, the absolute end point for getting treated for cataract is only functional disability for that particular person's occupation.
Okay.
No longer we wait for the cataract to mature.
Oh, before they used to say.
Before they used to say that. That is again a misconception. We never wait for the cataract to mature. See, you take a farmer who is having, say, very average vision. For him, that average vision should be fair enough for him to go with his normal day-to-day activities.
Okay.
Normal routine. You take another, say, an executive or senior executive in an MNC company or a bank manager. For him, if he is not going to be like having a perfect vision, for him, no, that's going to be detrimental for his quality of his occupation or whatever, even quality of life. So it is only the functional for the particular occupation. If they have a functional disability, it is time that they consult an ophthalmologist and find out what the problem is. And if the lens has started becoming cataractous, it's better it is just removed and exchanged with an artificial lens.
Okay.
So the extracapsular cataract extraction, whatever I was telling you, I'll just try to tell you what it is. So previously what they were doing was, they used to have a 13 millimeter opening of the eye. Obviously the lens is placed somewhere inside, and it has to be, we have to go deep inside.
Okay.
And with the 13 millimeter opening, the eye is entered.
Okay.
You see the lens that is there, that white round thing that is there is the cataractous lens. So once that lens is there, the light is not able to go into the retina, and the image formation is totally blocked.
Okay.
So with such a block in front of the eye, the patient will be invariably having a lot of difficulty.
Okay.
It will be a foggy vision for the patient. There will be a lot of disturbed colored halos. So what we do is, in ECC what we were doing was, like 13 millimeter you construct the wound, then you remove the cataract manually, and then whatever wound has been created, like it has to be again reconstructed by means of sutures. There is no modern day cataract surgery, whether ECCE or extracapsular cataract extraction or phacoemulsification, without putting an intraocular lens. So whatever you're seeing there is the intraocular lens.
Okay.
So whatever is taken out, we work up the intraocular lens power prior to the surgery, and that particular lens power, that particular lens is actually implanted into the eye. And whatever is the opening that has been produced is again, stitched back. So
Okay.
that is actually the suturing that we do.
Okay.
So this particular procedure, I will not say like it is a very bad procedure. It has again given vision for so many patients. But as and how the technology has advanced, we have now adopted to, latest technology called phacoemulsification. The problem with sutures is, of course, you have, the patient may have a little bit of sutural irritation, and with the big wound, you get a lot of residual refractive error called as astigmatism. So all that has been tided over by means of one new procedure which is called as the phacoemulsification. So the phacoemulsification per se, what happens in phacoemulsification is, in phacoemulsification, the wound size is hardly around 2.5 to 4 millimeters. The actual purpose of going for phacoemulsification is you are tiding over the sutures. So once you are not putting the sutures, that means the residual error, whatever is because of astigmatism or sutural irritation, or again calling the patient after 3 months or 6 months for removal of suture, all that is avoided. So, and it does not require any hospitalization. Again, like classic, almost ophthalmology has evolved to become a daycare procedure.
Okay.
So, even your phacoemulsification is again a daycare procedure. Unlike classic, usually, phacoemulsification, because it's an intraocular thing, whatever we do 1 eye at a time. 3 days prior, we start the patient on antibiotics. And once the eye becomes all right after 3 days, once the patient is fit, then we put the patient on the phaco procedure. So what you're seeing there is the phaco per se means like you're using ultrasound waves to actually lyse the lens, remove the lens. You're going to aspirate the lens with a fluid-like substance. And then in just a 3 millimeter to 4 millimeter wound size, you're going to implant the intraocular lenses inside.
But you're not going to suture at all?
No, absolutely. There is no suture that is involved. So it's a sutureless procedure, painless procedure, no hospital
But that 3 millimeter is also...
It's a self-sealing wound.
Okay.
See, beyond a particular, length only, you need to suture it.
Okay.
It's a self-sealing wound. So absolutely no hospital stay, early post-operative rehabilitation. And even with the intraocular lenses, you would have seen in those videos, like we were just putting in some lenses. The lenses also have evolved so much. The patients are so much demanding. The technology has also advanced so much that we have lenses for almost all needs, visual needs. Lenses are predominantly either monofocal or multifocal. By monofocal, like how all of us at one point of time, we would have visited an optical shop and asked for glasses. So beyond 40, 45, like how you have a bifocal or a progressive glass as far as the spectacles are concerned, even in intraocular lenses, you have different types. Monofocal means that is going to cater to only the distant vision or the near vision. It is going to cater to only one single vision need. Whereas multifocal means even without reducing your dependence on glasses, it is going to give vision at varying distances.
It's almost like getting a new eye.
Yeah, it's almost like that. Provided, the patient meets all the preoperative essential criteria, the surgeon is also qualified good enough to do it. And even in times of, if at all any complication happens, it is nothing that it cannot be salvaged. Even the complications can be managed if at all you get a surgeon who is informed about it and a patient who is ready to cooperate with the surgeon. So it's absolutely a safe procedure per se. Modern day cataract surgery is a very safe procedure. It's an OPD procedure and absolutely, hassle free.
Okay. See, even seniors are very, as you said, after 60 cataract is common. Seniors are also surprised that they don't have any more glasses and near very good vision they're able to see, isn't it?
That is true. That as I mentioned earlier, depending on the lens, whatever. See, it again depends. See, each and every technology comes with it. There's a lot of responsibility that comes with it. You have to select the correct patient, the proper patient, and his needs have to be taken care of. Okay, if you predominantly, for instance, you get a housewife, there is no point in motivating that particular patient for a multifocal unless and until she asks for it. Okay. She'll be very happy with a monofocal lens and just go for, near vision glasses for near. On the other hand, again, if you take an executive who's into a lot of system work and who's a lot of distance work and near work, again, going in for, progressive glasses or bifocals for the residual layer is going to be cumbersome for him. Okay. So the affordability also dictates everything. The clinical condition of the patient also dictates the lens that has to be put, and a lot of other factors we take into consideration before we decide on which type of lens has to be implanted for the patient.
So it depends upon what type of work they do, what they are, and also the clinical whatever.
Their expectations and the clinical picture, whatever we come across pre-operatively.
Okay, now let's talk about diabetes and eye, because diabetes mainly people do say that you have to check your eyes every year or every 6 months. So what is the criteria for an eye and the diabetes, how it affects it?
See, as far as diabetes is, again, out of the 45 million people who are blind, more than say 20 to 30% of it, the blindness occurs because of diabetic and hypertensive retinopathy. Okay. What really happens, see, the problem with diabetic and hypertensive retinopathy, and as and when it affects the retina, what really happens is the retina undergoes damage in such a way that it is very difficult for us to give back whatever vision is lost. We can only prevent further progression of vision loss. Whereas cataract is on the contrary, as I've mentioned, cataract totally you can give back the vision. Okay. Whereas when it comes to diabetic retinopathy and hypertensive retinopathy, again the visual prognosis is guarded. As and when the patient, see what the normal statistics says, like there is a huge chance that after 10 years of the onset of diabetes mellitus, around 30% of the population is prone to get diabetic retinopathy. Okay. At the end of 30 years of onset of the disease, almost 90% of the population will show changes in the retina, suggestive of diabetic retinopathy. Okay. So the statistics is so alarming. So when it comes to diabetic retinopathy and hypertensive retinopathy, the key and the corner stone of management is early diagnosis. Okay. Early diagnosis, how you can go about early diagnosis? You have to motivate the patient to come for frequent follow-up. Depending on the grading, primarily when the patient visits the ophthalmologist, we grade the disease into various categories. Depending upon the severity of the disease, you call them for frequent follow-ups. Everything said and done, it is always safe for the patient to have their glycemia under perfect control. They have to go for strict glycemic control and go for minimum, every 3 months it's better they visit the ophthalmologist. Yeah.